Hello, friends. Today's case. A 65-year-old woman presents to emergency department with sudden onset of high fever, low blood pressure, that is systolic blood pressure less than 90 millimeter of mercury, and vomiting. She reports having a small cut on her leg that she sustained while gardening a few days ago. On examination, she has an erythematous rash on that may discriminate and appears confused. Her heart rate is elevated and she is experiencing muscle pain. The laboratory test reveals renal dysfunction and coagulopathy. So please recall that we have seen similar kind of case earlier also, and what it could be. I give you few seconds to think on that. So yes, it is a toxic shock syndrome, but here it is caused by streptococci. So it is a streptococcal toxic shock syndrome, mainly caused by Streptococcus pyogenes. Now, how, so, why, what should we do, how we should treat, investigate? Let us see that. First, let us understand the pathogenesis. So the risk factor for this streptococcal toxic shock syndrome is that older age, as in our case, age more than 65 years of age, any surgery, any viral infection, usually varicella, which leads to open sore formation, diabetic patients, alcoholic patients, these are the vulnerable population. The trauma or surgery usually introduce bacteria and causes colonization. And this streptococcal pyrogenic exotoxins, which is SPE, they are released and they are diffused systemically. And this SPE, they are basically super antigen, just like staphylococcal TSST1. If you have not seen that, see the case 1 in this series. Due to large size, it cannot be phagocytosed by APC and it binds to V beta region of T cell receptor and MHC2 on APC, that is antigen presenting cell laterally. Being protease resistant, it provides constant unregulated stimulation to CD4 T cell and it facilitates excessive cytokine release, which is known as cytokine storm, mainly consisting of interleukin 1 and TNF, that is tumor necrosis factor. And that leads to acute fever, skin rash, discommission on palm and sole, and hypotensive shock, which may ultimately cause the organ hyperperfusion and dysfunction and may result in death. So 2 to 6% mortality is seen even with treatment. So let us see a picture showing the mechanism of action. So let us first understand the normal antigenic mechanism. So normal protein antigen, it is phagocytosed by antigen presenting cell, and peptide subunit or peptide representation is done by MHC2 receptor, which is present on APC, to the T cell receptor on CD4 T cell. Now, this protein or peptide unit, it gives signal to the CD4 T cell, which causes cytokine release, mainly IL-1 and TNF. But there are two things to consider. It is protein, which is protease susceptible. So once it gives a signal, it is destroyed. And second, this signal is one time causing a limited release of cytokines to do its function. Now, on the other hand, if it is a super antigen, just like TSST1 or SPE in that case, because it is very large in size, APC cannot phagocytose it. But it has affinity towards B beta region of TCR and MHC2 region on APC. So it goes there and binds laterally. Now, because it is protease resistant, the protease enzyme cannot destroy it. So it provides a constant stimulation by sticking there. And this constant uncontrolled stimulation will cause an unregulated, unlimited supply of cytokines, that is IL-1 and TNF, which is considered as cytokine storm, and which causes an body to go into an inflammatory state all the time and causing multi-organ failure, death, and hypertensive shock. That is basically toxic shock syndrome. So, which investigations we should do? A laboratory criteria for diagnosis is that culture isolation of Streptococcus pyogenes from blood, CSF, or tissue, or biopsy is required for diagnosis of this condition. The clinical criteria are somewhat different. You should need a hypertension, which is present in our case, and two or more of the following: either renal dysfunction, liver dysfunction, coagulopathy, ARDS, erythematous rash, which may discriminate, and soft tissue necrosis, that is necrotizing fasciitis or myositis. Now, let us see our case, what was present. So, hypertension was present, right? There is a rash which may discriminate. There is muscle pain indicating myalgia and renal dysfunction and coagulopathy. So as you can see, we have so many criteria. Hypertension, there is coagulopathy, there is erythematous rash, right? So it fits into streptococcal toxic shock syndrome clinical criteria. And culture isolation from blood CSF or tissue biopsy will confirm it. So that is to be done next in this case. So what should be the treatment? Because it is shock. So first you manage the shock with fluid replacement and vasopressor. You give systemic antibiotics. That is IV penicillinase resistant penicillin. Antibiotics are not curative. They kill bacteria, but they cannot remove the toxin which has already been released. So we can do two things. First, we will inhibit the new toxin production by giving a protein synthesis inhibitor, that is IV clindamycin. And second, if condition is not improving after that, then we can add IV immunoglobulin to neutralize the toxin, 2 gram per kg body weight. And higher doses are usually needed in streptococcal toxic shock syndrome, so that is to be judged clinically. There has to be a source which was releasing this bacteria. So source removal, identification of source and its removal is very important and urgent. So any foreign body, tampon, surgical dressing, any purulent collection should be removed. And future therapeutic options which can one can be working on is that antibodies which inhibits the cytokines, that is IL-1 and TNF. So I hope that this is very clear. Toxic shock syndrome is a very important topic, either staphylococcal or streptococcal. It can be asked in various formats.